Hello and welcome back to another edition of AHRA's podcast series, Medical Imaging Matters. I am AHRA's Executive Director and your host, Jason Newmark. So I could not be more excited about this episode, where I am joined by two experts in the radiology and gastroenterology world. Dr. Mark Klein, a radiologist who has performed more than 8,000 virtual CT colonoscopy or CT colonographies, and he's the co-founder of ColoWatch, a company focused on enhancing the use of this screening tool. And my dear childhood friend, Dr. Randy Pellish, current chair of gastroenterology at Leahy Hospital and Medical Center in Burlington, Massachusetts. Together, we take a closer look at virtual colonoscopy, its role in improving access to screening, the patient experience, clinical workflows, staff workflows, how it's viewed by gastroenterologists, and the key operational, clinical, and cultural factors that drive successful program adoption. Dr. Klein and Dr. Pellish have a great deal of perspectives and lots to say. So without further delay, on to the show. I couldn't be more excited. I get a chance to chat with one of my childhood friends and someone else who I've gotten to know very well over the last several months. And today we're going to talk about virtual colonoscopy. And we're going to talk about how accessible it is around the country and around the world. We're going to talk about it from a radiologist perspective. I'll throw in some administrator ideas, and we'll also have it from a gastroenterologist perspective. So we're going to hit you from multiple angles. But to get started, why don't we just introduce everybody that's on today? So first, we'll start off with Dr. Mark Klein. Why don't you say hello?
Hi. Well, thank you, Jason, for inviting me. And Randy, I'm looking forward to our conversation. I'm Mark Klein. I'm a radiologist. I have been teaching the course for virtual colonoscopy, the course on virtual colonoscopy, also known as CT colonography. Unfortunately, it has two names. It's the same study. I've been doing this at the American College of Radiology for almost 20 years. I've been involved in this for over 25 years. And I have recently dedicated my time and my energy to expanding the availability and the performance, enhancing the performance of virtual colonoscopy nationwide. And as we'll get into in a little while, I'll explain to you why I have done so and why I am convinced that virtual colonoscopy should be the screening test of choice in average risk patients around the country. And Randy and I can get into why I think that and why he might think it's not. But that'll be fun.
That's right. That's the whole point of today, right?
Yes.
All right. So Dr. Randy Pellish, why don't you give us a little intro?
Thank you. So it's true. I've known one of you for a long, long time and one of you for a much shorter time. And I'm really happy to be here. I'm an academic gastroenterologist in that I've been working at academic medical centers my whole career. I'm presently the chair of the division of gastroenterology at the Leahy Clinic, which is one of the academic medical centers just north of Boston. And I'm an associate professor of medicine at UMass Chan Medical School. And I'm the director of the Leahy Inflammatory Bowel Disease Center. So I spent most of my career taking care of patients in the realm of GI, but specifically with inflammatory bowel disease, Crohn's disease, and ulcerative colitis. And I spend a lot of time doing colonoscopy, as just about any gastroenterologist does. And so I certainly have a lot of experience in how the clinical applicability and access and what it looks like to have a good colon cancer screening program that ideally can serve and have the ideal of access for patients as broadly as possible. So excited to sit and talk with everyone.
I love it. And also, before we dive in, I have to say, so the listeners may not be able to see the video, but right over Dr. Klein's shoulder, there's a Union College chair. And I think it's great that we have 3 Union College alumni on the call today, right? So Dr. Klein, I think you were there a little bit earlier than Randy and I, but not that far. Right?
Yeah, I was there first, that's for sure. I won't tell you exactly when because people probably turn off the podcast. But yes, it is funny because we didn't plan this. I mean, you and Randy know each other, but we met Jason within the first 5 minutes of our conversation. I don't know how exactly it came up, but you said you're giving us your history. And you said, I went to you said something along the lines. I went to a small school in upstate New York, which for anybody who went to Union College, that is a giveaway, right? As soon as you hear that, your ears perk up and you go, come on, really? And we've all run into people in crazy places that have said the same thing. So it's a lot of fun to be with two guys who also attended Union.
Yeah, I thought it was really funny. When I called Randy and told him we had that connection, we were just laughing. I was like, what are the odds of that? I thought about maybe in the background when we get started, we'll play like the Let the Grecian Dream, but we'll have the song playing quietly through the podcast,
I could still sing this for you if you'd like. And I'll just say we're not that young anymore, actually. So it's all relative.
we were in upstate New York, Western New York recently, and there was something I was watching in a museum. It was about the Erie Canal, interesting. But then I did Cornell. They were playing the Cornell theme, and I turned to my wife and I said, "Would you like to hear the Union College, song?" Right? And I still remembered the first verse. After that, I wasn't any good. But anyway, we should talk about something more important.
I know, right.
Right.
Let's see how far we've all come from there, which is
Right.
fantastic, and to end up in this role. So I'd love to jump in though. So this is a real interesting topic for me, right? Obviously, I ran large imaging services, multiple hospitals in New England, and the idea of coming up with new exams that create more volume, but also better ways to diagnose patients that creates downstream revenue, help us, plan to take care of patients better or catch things earlier. These are all things we are always trying to pay attention to. And then, when you think about the colonoscopy world, this has been something that's been around for a little while, but I think it's more catching on as of late. I mean that specifically on the virtual colonoscopy. So maybe Mark, you could talk a little bit about, maybe we do this. Maybe we stop for a second. Let's talk more a little bit about what's going on in the world of colorectal cancer, right? And why is this becoming something so important as of late, and what's happening there? Maybe the two of you can weigh in, but maybe we'll start with you, Mark, and we'll go from there.
Well, I'd actually like to start with Randy, and I'll tell you why. He's in the clinical arena every day. I have a faculty appointment, which I really, at George Washington University Hospital, I have to admit, I haven't taught there in a while. But he is currently he's been an academic gastroenterologist, and I think it's more appropriate for him to weigh in on why we screen for colon cancer, why it's important, and what's happening currently, especially in younger age groups.
Love that.
Sure, I'm happy to. So certainly in the realm of cancer screening, and there's many different types of cancers that we screen for. Colonoscopy is amongst the successful stories, or I should say cancer screening for colon cancer specifically is one of the I think successful stories that we have for identifying and screening patients for cancer that hopefully allows us to diagnose it at an early stage, or I think also I think for colon cancer have the opportunity for a preventative type of approach. I think there's a lot of probably for your constituents or people listening to this, certainly mammography comes into the realm of understanding cancer screening in general. And so that really we are, I think as a country that doesn't really have a healthcare system, so to speak, but we have done a good job to elevate colon cancer screening into a really meaningful place. And yet it's still not where we'd like it to be. And there's a lot of difficult topics there, including very briefly to touch on the unfortunate circumstance where there is some increasing rates of diagnosing colon cancer even earlier than the age of 50, particularly in what are called distal cancers, meaning lower or even rectal cancers. And what does that mean for how we think about setting up a system and a program that ideally screens as many people as possible to identify cancer before it becomes something that's more difficult to treat. So I think that we find ourselves, though, even though we've had great success with this, that like so many parts of lots of cancer screening programs or just general medical problems and general medical care, that we have an issue with access, which essentially is probably where I encounter it running a group of gastroenterologists on a daily basis. Each patient receives amazing care, but part of it is getting the people into the door to get the screening test that they really need. And so I think that across the country, this is a very, very difficult topic. My understanding is regardless of geography, whether you live in an area, perhaps like where I am in Boston or in New York City, where there's a remarkable critical mass of hospitals and different ways that people can have colon cancer screening. And yet we still have people waiting and waiting and waiting. And that I think also applies to areas where perhaps there's different geographies and there's not as easy access to care just from the standpoint of distance and time. So I think the access part is a real tricky one, which is really what's so meaningful about this conversation today, because we really want to provide access so that patients can have the opportunity to get cancer screening, colon cancer screening, in an easy way that works for the individual patient. And I think we'll probably talk about.
And to your point, it may not be so. There's the general colonoscopy, but there might be other alternatives if there's access. And when you say access, you're talking shortage of gastroenterologists, shortage of the nurses, shortage of the staffs, shortage of locations that offer that type of service, right? So you're basically saying that we have to be open to other ideas and other ways to screen folks, right? I'm just sort of interpreting.
Yes,
whether you're driving that.
Okay. Treat the most patients we possibly can, screen the most patients we possibly can.
Now, do either of you have any, I don't know if we need statistics or maybe you do have some, What about just like the prevalence of colon cancer? Is that something that we're seeing more of nowadays? I mean, I don't know, the diets are different, things are different. I think, is that something that,
Okay, if I take a swing at this,
Please,
Randy?
please. Yes,
Yeah.
yes.
So Randy mentioned something very important, that there's a rise of colorectal cancer in younger people under the age of 50. So that's increasing by 1 to 2% per year. So colon cancer in older people is actually dropping or not increasing at anywhere near that rate. But colon cancer among younger populations under 50 is soaring. So if you were born in 1990, compared to a person in 1950, you have twice the risk of colon cancer and 4 times the risk of rectal cancer. If you look at the United States Preventive Services Task Force, that's a group that a semi-government organization that determines screening policy in the U.S. They lowered the age a few years ago from 50 to 45 to meet this problem. The issue, though, is that if you look at all the under 50 age group, more than half of them are under 45. So they lowered the age to 45, but you're still missing more than half these people. So that's one problem. And what Randy said before about access, places in this country, it is variable. A place like Boston, you're in the mecca of healthcare in this country, and New York certainly is one. There are a bunch of them, but certainly Boston's right up there. So I don't know, it might be easier to get a colonoscopy in Boston than other places, but there are places in this country where wait times are 6 to 12 months. So for colonoscopy. And I think the other thing we could agree on is that, people say the best form of colon cancer screening is whatever you'll get. And I think I'm going to bet Randy and I don't actually. I think we agree that that's probably not an accurate statement, because not all colorectal cancer screening is the same. So, for instance, colonoscopy, very good at finding cancers, well over 90%. In fact, and then for polyps, it's also very good in the 90% range. A virtual colonoscopy, if you look at the studies that compare them head to head, a little better for larger polyps than colonoscopy. And for colon cancer, for actually looking for colon cancers, there's no direct study, but if you look at studies where there were 2 arms, some having virtual colonoscopy, some having colonoscopy, generally speaking, the virtual colonoscopy arm will be superior, especially in the right colon. So there's a lot of studies on this, but that doesn't really matter. The point is those 2 studies are very good, right? So, but on the other side of the coin, you have the stool tests like Cologuard or FIT tests, certainly the new blood tests, which I'm sure Randy and I also are going to probably agree on. Yes, it's better. Something is better than nothing, but that misleads patients, because stool tests cannot find polyps like the other 2 tests, like virtual colonoscopy and colonoscopy, reliably. It can find some, but it finds less than half of the sleeping polyps. The blood tests are even worse. They miss 87% of the polyps, according to their literature. If you watch a commercial on TV and you see this, you go, how did these people get FDA approval, right? They can't find any polyps. And as Randy said, you want to find the polyps because they tend to be the precursor of the cancer. So I would say that the way that he and I both approach colorectal screening, him with colonoscopy, me with virtual colonoscopy, I would say they are literally heads and shoulders above the alternative tests, blood tests and stool tests for finding the disease at a point where you can do what Randy's talking about, either prevent the disease completely or certainly find it at an earlier stage where the morbidity or mortality is much lower.
Got it. And we're going to keep reinforcing, I think, a lot of the wonderful things that hopefully we're stating. I want to, and so Mark, I appreciate the way you're identifying lots of outcomes that actually are fairly complex. And I think that's part of what we're trying to understand, all these different modalities, all these different types of tests that are available for colon cancer screening. It's important to think about these different outcomes. The main outcome is we want to prevent death. Unfortunately, that does occur with colon cancer as the first way of assessing the test. And then we start getting into sort of, I would say, these smaller spheres that talk about identifying polyps. And then maybe the next is the size of polyp. And then the next may be the type of polyp. So there's a lot of different ways that we can talk about what is the benefit, really, what is the outcome that we're hoping to achieve with each of the different types of colon cancer screening tests. And not every single one, and certainly CT colonography and colonoscopy are really I think, set the bar for ideally identifying all of the ones I just spoke about. Perhaps there's a little more detail to that, like probably everything we'll talk about today. But I think that you're very right to point out lots of different outcomes that we're trying to measure to determine which test is a good one.
Yeah. Well, so in that, maybe we dive right in then. So based on saying that groundwork, which is helpful, I think it's helpful for me. I'm learning as I'm talking to you guys, and there's things, this is the world you guys are in every day. So let's talk about virtual colonoscopy a little bit too, because I think there's a misnomer out there that either all gastroenterologists don't like it, right? Because it takes away from someone scoping. I've heard that many times. Or administrators will say, oh, it's just one more thing we got to throw on the machine. It's too complicated. We don't have the training. I don't want to do it yet. Or can I get paid for it? How do I train people? How do I read for it? And, all that kind of stuff. there's people that are going to ask about preps. What's the difference, right? This, that, or the other. So maybe we just start there, and maybe we'll have Mark, you drive in and to talk about your kind of overview of what it is. And then maybe the two of you can just weigh in on both your perspectives about, the safety quality considerations, or what does prep actually feel like and look like that's different, and just some of the things that are more tangible, I think listeners would like to hear.
I completely agree. So real quickly, what a virtual colonoscopy, again, two names, virtual colonoscopy, CT colonography. I hate that there are two names, but they're out there. So the people know we might use them interchangeably. So it's a CT scan, basically. So what happens, a patient takes a prep, not too dissimilar from a colonoscopy prep. We try and use a prep that's lower volume, but certainly Randy could do the same thing. So it's not a magic prep. It's actually a very good prep. And I've, I used a couple of different preps. I've worked on them over 20 years, and I think they really work. I know they work fantastically well, but it is a prep, and we don't want to tell people you're not. We also give a couple of other things, because when you have a prep with a virtual colonoscopy, you're almost always going to have a tiny little bit of stool left, not a lot, if we do it right, and you're also going to have fluid left over. So we want to be able to see under the fluid, and we want to know what something is stool rat, so we know it's not a polyp. So we give something called tagging agents, which is very simple stuff. It's a little bit of the barium, kind of like you would take for an upper GI series or something, but nowadays they taste much better. They come in flavors,
you
banana.
Drink it.
You drink it. It's an oral barium thing. It's very easy. It's like a milkshake. It doesn't taste chalky or terrible like it used to. It's easy. And then we also give a little oral iodine. So we use something called gastrographin. There's a little gastroview. It's just, we use 1 ounce, literally 1 ounce of this at the end of the prep before the patient comes in the next day. And that makes all the fluid visible. So that's how you do the prep. You come in. One of the things that's very nice about virtual colonoscopy, CT colonography, is there's no sedation. So nobody has to drive you. You don't have to take a day off for work. So we like to do these early in the morning because patients haven't been eating very much the day for a colonoscopy or a virtual colonoscopy. So we don't want to keep them waiting. So we do them. If you come in, for instance, at 8:00 in the morning, you're out the door at 8:30. You can go to work, you can go shopping, you can go play golf, you can do anything you want. You're going to feel pretty much exactly the same on the way out as you did on the way in. No sedation, essentially no risk. In the 25 years we've been doing these, there's never been a death worldwide. I don't know anybody that's had a complication. And I work with the major players in this area who've been doing this for many years. None of us, I'd say among my colleagues, 40,000 cases, nobody's ever had a complication. So I never say to people it's impossible, because as we know in medicine, anything can happen anytime, but it's a very, very, very safe procedure. So what happens when you come in, we actually put a little bit of we put some carbon dioxide in the colon through a very tiny little flexible tip in the rectum. You barely feel it. We put some carbon dioxide in that distends the colon. We do 2 CT scans. Each one takes about 8 or 10 seconds. About a minute and a half between them, and then you're done. You're off the table. So the actual scan time is under 10 minutes. You're on the table. Some 10, 15 minutes, no more than that. Then you're out the door, go do whatever you want. The day is yours. So that's kind of how it's performed.
Got it. So basically, patients are prepping at home. Similarly, you drink your stuff, you have your fun at home, and you're all cleared out as much as you possibly can. You come in, you get your study, but unlike having the full colonoscopy where you're going to be sedated, you're there a bit longer, you got to wait after for the recovery. This sounds like you can come in, you're in and out, like really, really quickly. And you're only tying up the resources of the medical imaging department for a very quick period of time.
About 15 minutes.
Okay, got it. All right. And then, and Randy, anything you want to add to that? I mean, I know you were talking about different angles. I mean, I'm always curious, like you think you and I were talking earlier, and you said, and I was surprised, you said, yeah, I actually order them sometimes. Like, maybe you can speak to how that comes up in your world before we get into a little bit deeper here about, from the other side of the shop, right?
Sure. The pathway to getting colon cancer screening admittedly starts, I want to call out the people who actually really sit with patients and have these discussions in the most meaningful way, is the world of primary care physicians.
Yeah.
And I think it's an important point, one, to give them the credit, because it's actually, when you have lots of different options, knowing at the same time that, and I think in our conversation, we're supporting 2 of the options over others, but it is a complex discussion that a primary care physician is faced to have with a patient who may have a variety of different characteristics that may push them towards one test or another, including the amount of time they may have, whether they're willing to take a prep, whether they have someone to drive them. Because to Mark's point about sedation, we do provide sedation in, I would say, 99, if not higher, % of the patients who undergo colonoscopy. So there's a lot of different, very, I think, specific parts of the discussion that actually have to be had by primary care. So that's the first part I wanted to make. And I think that's because when we're talking about it from us, you've alluded a bit to if you're a hospital or a system and you're trying to figure out how to have these different colon cancer screening pathways available, it's also incumbent that the primary care physician world understands the pathway for patients actually to make their way to whatever test they ultimately choose. So that was the first point I wanted to make. I did want to say, by the way, that I think we didn't state the overall lifetime risk of colon cancer that you asked, actually, which is about 4 to 5% for average people. I just wanted to throw that out as a little side point because I think you asked that question before. So what that means, though, in terms of the way of accessing colonoscopy is that, and I think it's similar to what would happen in radiology, is that it's essentially a system that we would call open access or direct booking, where, again, that primary care physician makes a decision along with the patient, and then an order is placed for either CT colonography or for colonoscopy. It is true if we were having the conversation, and sometimes the gastroenterologists do get involved because patients will come to us and perhaps even want to talk about they've had one colonoscopy before, what are the other options they may have going forward. And so we do bring into the discussion aspects of talking about a prep. Our preps are very similar, and we have been working very hard, but frankly, not with making any paradigm shifting changes to come up with a way that people would tolerate preps better. And that's a very, very significant obstacle for many, many people. We also have the discussion on risk. The risk really discussion occurs when we're consenting patients, and there is very, very small, but I think it is important to state there are risks of essentially bleeding in the setting of particularly polyp removal. And there is risk of causing what we term perforation, meaning a hole that could occur in the intestine. These are very, very uncommon things. We're talking about 1 in 10,000 types of numbers, but they do exist. And certainly, if I go back to this idea I was talking about of any kind of cancer screening, we always want to make sure we have a test that is both safe and acceptable to patients so that they're actually willing to have it. But the acceptability does take into account the risks that are associated with it. And certainly we think that considering the risks are very, very low with the definitive upside of colon cancer prevention, certainly it's a recommendation that colonoscopy is a very, very acceptable and certainly the most common modality in the United States that's used for colon cancer screening. The other points I would just make in terms of how patients come to us to have discussions is that there is the aspect as well about because you're getting sedation and because you're having a procedure that we have to take into account what we often term comorbidities, but essentially the health of the individual. Now, often we're talking about screening people who are either very, very healthy or relatively very, very healthy. And so there's little concerns about any of these tests in terms of being an impact on their general health. But I'll give you one example of something that it's a complex aspect that we deal with colonoscopy is that because we're doing a procedure where we may be removing a polyp, we have to assess, for instance, if people are on blood thinners. So it's a layer of complexity that even for someone who's coming for their first colonoscopy, if they take a blood thinner for some reason like atrial fibrillation, that's something that we have to take into account that for CT colonography, for that test, it doesn't make any difference. And I think the other part is that because we're giving sedation, we're in the realm, I think it's an interesting point to make, because we now live in the era of these amazing medications, the GLP inhibitors, they play a role as well in terms of understanding how patients may need to avoid those medications because they're getting sedation and there could be risks with have those medications interfere with emptying of the GI tract. I bring it up, it's a little bit of an extra layer that maybe is beyond what is necessary for us to delve into, but it does show there's more complexity with scheduling colonoscopy.
Yeah.
So you said,
can I just jump in for a second?
Yeah, jump in. Yeah.
Let me jump in because I think, Randy makes some great points. So first thing I want to say is that we are going to contrast virtual colonoscopy and regular colonoscopy. But I think the most important thing I would like people to get out of this is that if you're going to have a screening test for colon cancer, it ought to be able to find the lesions that the entities that when taken care of can prevent the colon cancer to begin with. So I think we agree that's what you want to do. A screening test, unlike mammography that Randy mentioned, I'm going to mention that again in a minute. We are not looking for cancer per se. We prefer to find what we call the precancers, the polyps, the adenomatous polyps that can lead. Most don't, most are fine, but some will lead to cancer. And if we remove those ahead of time before they ever get close to being a cancer, guess what? Good chance that patient never gets cancer. So And the only tests that can find those reliably are traditional colonoscopy and virtual colonoscopy. The stool test and the blood test cannot reliably do that. So at the end of this conversation, if all we agreed upon was that, let's get people away from stool tests and away from blood tests and to one of these visualization tests, meaning we can actually see the colon. I'd be great with that. I think it is fair to spend a couple of minutes talking about colonoscopy versus virtual colonoscopy. I've had colonoscopy. I've had virtual colonoscopy. And the old joke is that a lot of my friends are gastroenterologists, which is true, right? And I live in the Washington, D.C. area. There are some excellent gastroenterologists. By the way, Randy, a bunch of them have come to me for their screening because although they do colonoscopies every day, they're a little afraid of being put to sleep. They're a little afraid of perforation. So the numbers, Randy's right. Complications of colonoscopy are not common, but when you're talking about huge volumes of people, they add up. So for instance, there are about 15 million, and you can correct me if wrong. By the way, Randy, everything I'm saying here comes directly from your literature. We don't talk about this in the radiology. This is all from the GI literature. The American Society, the ASGE, for instance, has periodically does these articles. That's a gastroenterologist publication. So pretty standard. They estimate about 7 per 100,000 deaths. So for every 100,000 people that have a colonoscopy, 7 people die. Well, that's a very small number. Randy's right. But you multiply it by 15 million, you end up with over 1,000 deaths from a screening test. So that's something that patients should know. For instance, the other thing is about 4 or 5 per 1,000 have a complication, either what the ones Brandy mentioned, bleeding, perforation, meaning a hole in the colon, which can be extremely serious. Splenic rupture, by the way, I've seen a bunch of splenic ruptures. I'm sure you have too. The reason is because the scope goes right next to where the blood vessels enter the spleen when you get a high on the left side. And you don't have to be clumsy to rip it off. It happens, right? So I'm going to guess Randy has had very few complications because he's an academic gastroenterologist. He's been doing this a long time. I'm going to guess he's really good. And he seems like a really good guy. So I would trust him actually to do this. The problem is there aren't that many Randy Pellishes. There are Randy Pellishes, but not nearly enough around the country. So when you go to have a colonoscopy, you are really very dependent on the skill and talent of the gastroenterologist. And most of them are very good at it, but not everywhere in the country do we have that ability. So one of the things you want with a screening test is reproducibility. So if virtual colonoscopy, and I'm adamant it is done correctly, and most places in this country right now do not do virtual colonoscopy correctly, I would tell you honestly, but we're trying to change that. But this can be standardized. It can be so that if you go into Boston, you say to one of your friends, Randy, let's meet at Starbucks, and they say, which one? You go, it doesn't matter, because you know they're all going to taste the same. Just go to the one that's convenient that has a table available, right? You don't say, well, the one down in Beacon Hill is much better than the one by Mass General. You don't say that. You know they're all going to be the same. And that's what we want from screening tests. We want tests that can be reproducible, that are not so much dependent on the skill of the operator. So there is definitely some of that in virtual colonoscopy, but very little, because we can standardize it. And with AI, it's really easy to standardize it. So that's one advantage. And the other advantage is that besides the lack of sedation, there are essentially no complications. So I want to go back to the mammography analogy again. So just again, I am not anti-colonoscopy, right? I just want people, I have one goal, and I'm sure Randy and I agree on this. As a doctor, you have one mission, that is to do what's in the best interest of your patient. That's it. That's number one. Everything else are shiny, bright objects that can distract you. And I think it's important that patients understand the benefits and the risk of every procedure. So in mammography, for instance, that Randy brought up, if you said to a woman, there's a 7 out of 100,000 chance that you could die from this test, or 4 or 5 per 1,000 chance you can have a complication, they'd all turn around and walk out of the room. I've done 30,000 mammograms in my life. I've seen 1 million patients, right? And I can tell you that that would not be acceptable. Now, in terms of colonoscopy, well, it's not like a mammogram for sure, but the idea is we want our screening tests to be as safe as possible. If every colonoscopy was done by Dr. Randy Pellish, it'd probably be a lot better, but they're not, right? Unfortunately. And so you want a screening test to be very accurate, very sensitive, meaning it can find the problem, very specific, that when it finds something, it's not nonsense, which is probably one of the problems with the stool tests. Most of the stool tests that come back positive are not cancer. Only 2% of the ones, 2 or 3% of the positive Cologuard tests are cancer. The rest aren't cancer. But all those patients end up to go into colonoscopy. So you want something reproducible, you want something safe. So at least patients should have a choice. So if you say to a patient, look, here's the data, here are your options for colon cancer screening, here are all of them, you choose. And if they say, you know what, I just want to go to get a colonoscopy, I am fine with that. Just make sure you go to Randy Pellish or somebody like him, right? But otherwise, I'm fine with it, but at least give patients the option. So I always say virtual colonoscopy is the best kept secret in American medicine. Nobody knows about this. Not patients, not primary care providers. They hardly know. They've not been educated. And so I just want patients to have knowledge, to have the opportunity to know what their options are, and to understand that there is a test out there that is super accurate and super safe, and nobody knows about it. And that's why I spent this part of my career. And those of you who can see me know I'm not 25 years old. Why am I doing this at this point in my career? It's because I feel an obligation, like Randy does, to improve the health of as many people as we can. That's why we're in this business. And so that's why I'm talking about this. That's why we're doing this. That's why I appreciate having the opportunity to talk to somebody like Randy about this. And you, Jason, of course.
Yeah.
Flattery will get you everywhere.
Well, probably with Jason.
Yeah, right.
Like,
I wish. You made any thoughts on that? Yeah.
Yeah, I have so many. It's a really fascinating conversation. I want to turn to one topic because so first I certainly want to echo the idea that we're trying to make the best decisions for our patients, and I do think that there is I always presume there's some difference on geography to some extent across the country, depending on the resources and the access and to hospital systems that can even create, let's say, a clinical pathway for CT colonography, and that's a big problem that there can be such variation. But with that variation, actually, I'm curious, Mark, because we really are struggling, I think, in the world of GI, broadly speaking, and there's different situations with access from one practice to another for sure. But what does access look like right now in, let's say, a fairly good sized hospital that has, I don't know, maybe 5 CT scanners in terms of being able to actually provide access for CT colonography? What's the state of affairs there? Because I actually don't quite know, and even in my own institution.
Well, I'm listening to something. It said he must know something.
I really,
but I'm just kidding. It's a very important.
Thousands of studies. The scanners rolling all the time.
It's a super legitimate question. And I hope after, we only have a short time together, but Randy, you're going to hear from me again because you're super interesting. You're very nice. And I hope we can continue this conversation after this podcast
Even
is
if
over.
Jason can't join us.
I don't care about Jason.
I've been bummed. I'm okay.
Right. No, but it's a good question. So the answer is that it's variable, like you said, but CT scanners are relatively cheap. I mean, the people listening is going to say, well, I'll tell you it's under
$1.5 million. Are you crazy?
Yeah, no. You can get a really good CT scanner for well under $1 million. Now, compare that to an MRI that's millions, or PET scans at millions, or a lot of some of the certainly fancy ORs with robotics. These things cost a tremendous amount of money. So I'm not minimizing it. It's just that it's not prohibitive, and they pay for themselves. For the hospital or an institution, they pay for themselves in no time. You don't need to do a lot of cases. So right now it's variable. Some places have a lot of open access, open slots. Some places have very few. You're right. It's very variable. But let's say all of a sudden the best kept secret in American medicine, virtual colonoscopy, all of a sudden becomes less of a world's kept secret because I'm spending my entire time trying to make that happen. Then it's easy for a facility to say, you know what? Yeah, we'll put in another, we'll rent 2,000 square feet next door and put a scanner in. It's easy. Putting in scanners is easy. So your point is very legitimate, very important, but it is something that in areas that are limited, it's easy to address. It's not difficult to address.
And right, obviously, the biggest thing we see in the hospitals, and the literature will tell you, is just the same thing you talked about: shortages of gastroenterologists. There's shortages of technologists. So getting younger people excited about going into the field of medical imaging and realizing there's multiple modalities and ways you can go. So when you're short-staffed, then the question becomes who runs the machines. And that's what causes most of the backlogs. Is having the staff available. Are they available after hours? Are they available on the weekends? Are they trained? Have they seen some of these types of studies? So we could go in a whole deep hole here, but remote scanning is a huge topic right now. So a lot of these new machines, the new technology allows someone who's a super expert to run a machine and not be in the room. Now, obviously, the questions are who's in the room and what safety is set up there. So is it somebody who's trained on radiation safety? Is it MRI safety? Are there licensure requirements in the state? Does it have to be a technologist? Like, there's a variety of things we can go in multiple directions, but the idea is there are people in the medical imaging space trying to address their capacity issues as well, right? So remote scanning and MRI, it's taken off right now. Again, with the right safety guidelines, the right requirements in place. And then maybe if you're in a rural area and you don't do a lot of cardiac or a lot of certain type of specialty studies, you can get Mark Klein, the MRI tech who does them all day long, to run the machine for you and do those scans so the patient doesn't have to drive 3 hours or be delayed or whatever that is.
Well, let me
think with CT, here?
Yeah,
right?
let me answer that. Yes. So first of all, I would say to people, if you're in school, you're young, you're looking for a job, go into the medical field, nursing, technology, because AI is going to eliminate a lot of jobs, but it's not eliminating these anytime soon. And patients don't even want it to be. They want people, and you need people. So I would say that we might be in a slump, in a kind of a trough right now, but that's going to go away. You're going to see, I believe, in the next 5 years, you're going to see a tremendous influx in people in healthcare, like nursing and technologists and things like that. Also, obviously, in the trades like plumbing and electricity, because some of the other jobs are going away to a certain degree. So, for instance, what I do, because I'm so interested in standardizing this, when we go to a site, what I've done, first of all, I've created a network of radiologists who want to read these, who I've trained. Since I've been teaching this course at American College of Radiology for a long time. So people who are interested, who I've trained, they do it on their own, either full-time or part-time. So you have to have very well-trained people. And most radiologists, Randy, if you ask around at LA, you're going to find that radiologists don't want to do these. Why? They're so busy. They don't want to stop and take the time to do something they're not good at, and they don't want to take the time. It takes too long. They'd rather read a case they can read in 3 minutes than one that's going to take them 15 minutes. So we've kind of solved that problem. And the standardization is, I insist that when we affiliate with the site, we teach them the text how to do it. I actually go there physically and show them how to do this, right? Because I'm a stickler. We have to do things right. So I teach them how to do it right. We teach them the prep. We give them the prep. We teach them the technique, how to position patients and so on, how to maximize the patient's comfort in the room, all these things. We teach them everything. Then we send the cases electronically to experts. So the reading is done remotely by people who know what they're doing. But in terms of the actual scan, you need people in the room, and and we teach them how to do this, and it's not hard. I can teach somebody to do this in no time.
Well, I like that you went there just to jump in. I like that because you kind of hit. I was going to ask the question, you sort of answered it as you were rolling there. I was going to say, for people out there considering a program, or maybe they haven't rolled it out yet, right? I think what you're saying is, hey, you're a resource, and there's other people out there, resources as well, right? You find someone else who's doing it, about what are the technical standards, what are the protocols, how do you get up and running? Obviously, you need your technologist to be able to be trained and do it safely and do all those pieces. And then if you're another part of the radiologist shortage, as you know very well, right? Very big problem with shortages of radiologists. If you're in an organization that maybe your radiologists are they're overworked, or they're doing other things, they don't have time for this, you can seek experts outside. And I think that's helpful for people to understand that you can still offer this, even if you don't have all those resources. There are available resources outside the organization that are expert, that do it all the time. Maybe you do that with them for a little bit until you gain that traction yourselves, or maybe you stay with them. Maybe it's a way to say, look, you do what you do really well, and we'll do what we do really well. And you sort of split those resources. But Randy, I saw you were leaning in. Were you gonna say something?
I was thinking to myself, you can't do a colonoscopy from afar.
Right. That's right.
I don't want to say you can't do it virtually, because that speaks a little to the language of virtual colonoscopy. Right. But you cannot do a colonoscopy from afar.
Can I ask Randy a question? So Randy, about 1 in 10 people who have a virtual colonoscopy have a polyp that needs to be removed. So they're going to have to go to colonoscopy. 90% of people, fine, they leave, go whatever, do whatever they want. 1 out of 10 is going to need something. So in my ideal world, what I have tried to set up, and so far it's been not easy, is to have a situation where the 1 in 10 people who have a virtual colonoscopy, have a positive, and can then go directly, same day, preferably, if the worst case overnight, they stay on clear liquids overnight, but to go directly, if possible, to a gastroenterologist to have that polyp or polyps removed, or a mass biopsy, whatever. So they don't have to wait, they don't have to prep again. It's all in one thing. What do you think about that paradigm, and how difficult do you think in your situation would be to arrange that?
So we should have that paradigm because it's good for people. It's good for our patients. And we do have the paradigm that is established in the alternate way. If we bring someone in for a colonoscopy, and for very uncommon, but in some rare circumstances, the patient doesn't tolerate the procedure well, we will sometimes send them immediately, meaning that same day, for a virtual colonoscopy. And we have a pathway at our institution that allows for that. We do not, to your very, very good point, have a pathway for the alternate, the other way. Exactly. The other way. I mean, from my standpoint, because I'm, I'll say, blessed to work at a place where I have 9 rooms doing endoscopy each and every day, that the capacity, and again, going back to this word access is like my true north and just about everything I do each day for our division. But I think in a scenario, or in a hospital setting where you actually have enough space for patients to fall into a schedule, it really should be something that we identify as an ideal. That being said, many colonoscopies, and I don't know a sense of the percentage, but are not done in a hospital setting. They're certainly done in a ambulatory surgical center, ASC kind of setting. And that may be logistically more difficult because my radiology group I'm telling you, they're about 100 yards away. And obviously for other practice situations, it may be more logistically difficult to have someone go to another facility, for instance. But it strikes me that it's this concept of integration. I mean, I'll kind of toot our own horn. I mean, I'm at a place, the Leahy Clinic, where we have remarkable integration because we have amazing physical space and we're all under the same roof, essentially, that allows for what you're talking about. And I think that the degree of, I'll use the word fragmentation, but we have a fragmented healthcare system that I think does make that difficult. But that being said, it strikes me that if as you're working to bring virtual colonoscopy to more places, should be, and I presume you do this, it should be with the idea that we would also create those clinical pathways that a patient who has a positive finding can fall into a schedule because to your point also, we're talking about a very small number of people. It's not like the radiologists are going to call me up and say, oh, today we got 10 and tomorrow, we may have another 10. You're talking about a few, maybe a week, depending on the volume that you'd be creating. So I do think it's very, very appropriate, and it really should be an ideal. And you're prompting me to think about how I should talk with my radiology colleagues about that.
My guess is your radiology colleagues don't want to do any more of these because they're probably swamped like everybody else. Yes, they all are. And this is why, I look at what, I tend to solve, like I'm sure you guys do. You see a problem, you try and, all of us are in positions where we have the experience, certainly, and the desire to solve problems. And this is one of them. Like, why can't we offer more access, as you said, to that great term, to patients from virtual colonoscopy? And the answer is, one, the radiologists don't want to read them, haven't traditionally want to read them. The other was what you said, Randy. Some gastroenterologists, or many gastroenterologists, weren't fond of the whole idea, especially 20 years ago. Now there's a shortage of you guys. You're in the same boat everybody else is. There's a shortage of gastroenterologists, there's a shortage of infectious disease, and shortage of radiologists. There's a shortage of almost everything in this country right now, and it's not getting any better. So, by now, I think that's why I think virtual colonoscopy is about to hit its stride. Because honestly, gastroenterologists like Randy, as much as they want, they can't really handle a whole lot more volume. There's not enough of them. And plus, you have the same problem also. You're a young guy, but about half the people in your profession right now are over the age of 55. So that's also a problem. So, now when we're getting it, we have a shortage of gastroenterologists who can't really meet the demand as the population grows and as the population age. We have a test that's fantastic. And so, I would say if we can just move patients right now, we can move patients away from these really not optimal screening cells like stool tests and especially those blood tests, and at least move them to virtual colonoscopy and then using that increased volume, because we're going to see 1 out of 10 is going to need a colonoscopy, which means they need to have polyp removed or a biopsy of something. Then we move them over. I mean, that's ideal for patients. It's quicker access to getting the best care. They're certainly keeping the cost down. By the way, I didn't mention this, but it turns out, and I have papers I'll send you guys if you want to see them, that virtual colonoscopy is actually the most cost-effective way to screen. It's better than much less. It's more cost-effective than stool tests, believe it or not, and it's true. I'll send you a paper if you're interested. It just came out last year. But anyway, that would be great. If we could just do that, we don't have to fight about colonoscopy and versus virtual colonoscopy anymore. It's not doing anybody any favors. And I admit I've been in the middle of this fight for 20 years, but I've realized, okay, people should have what they want, but let's let them know that there's a test that's way better than the stool test and blood tests, way, way better, more sensitive, more specific. It can really save their lives. And then let's move those patients who need to our colleagues like Randy, the gastroenterologists, so they can treat them hopefully the same day if possible. And now we've really got something going. Now we can make a much bigger impact. And here's the other thing, Randy, I'm interested in what you feel about this. I'd like to, you can do virtual colonoscopies on people in their 30s without risking anything. Nobody's going to die. Nobody's going to hurt. All these people under 50 or certainly under 45 that are not anywhere in any screening program, we can safely do these people with a virtual colonoscopy. We're going to find colon cancers and significant polyps. We know that because you see the data. And then we can send them to Randy. That's how we make a huge impact. Now we've taken a group that has really no screening, given really, really excellent screening. And then those small numbers, they will be small numbers, can then go to Randy and get cured or avoid the cancer in the first place. To me, that is such a compelling thing. And that's what I'd like to see happen as we move forward.
Jason, I don't know how short we are on time. I had two,
Yeah,
I thought,
yeah,
interesting other points I wanted to bring up. One is I do want to certainly state, I think one of the important points about colonoscopy is being because it is not only a diagnostic, but a therapeutic procedure. And in many ways, I think that's also
Absolutely.
been part of the discussion and I'll say controversy around the choice of what to do, with the idea that if you could have, I'll say, one visit to the doctor, knowing that the visit of colonoscopy versus CT colonography is very fairly different. If you have one visit, and also with one prep, is that support colonoscopy, and that depending on how the patient feels about it. But I do think there is that aspect of just making sure we understand that the removal of the polyp, which certainly can follow a colonography, but as a primary, if you're having only one test, has, we think, a great value. And there is an extra detail about the possibility of flat polyps that we are somewhat uncertain, I think, in terms of the risk associated with those. So touched on it very briefly at the beginning of our conversation, that may not be identified by CT colonography. And I think that's something that does play into this controversy about the choice. The other was that is this idea of extra colonic findings. And I thought maybe that the radiology technologist would be very interested in understanding this other part, because certainly when we're doing colonoscopy, we're just inside the lumen. And there's this, I think you make the argument of good versus bad, or perhaps that's the bad way of putting it. But the idea that you would have other findings beyond obviously looking for colon polyps or cancer on the CT, and what's the implications for that? How are we dealing with that?
Oh, I love that question. Did I send you that one?
No,
Oh, I didn't.
no,
Wow.
Jason
What a
didn't either.
coincidence. So let's start with that. And
Union
then I'm going
college connection.
Yeah, maybe. So you're looking at a guy who had his first virtual colonoscopy after having previous colonoscopies, the first 13 years ago. And it's a really good story. I won't bore you, but the bottom line is my colon was fine, but I had a mass in my left kidney, which pretty good size mass, about 3 centimeters. So that's over an inch. I ended up called all my academic friends all over the country, and one said come to MD Anderson, and one said come to Boston, and finally ended up going to Hopkins. And I had it was a renal cell cancer. It was actually, it didn't look too bad, but it turns out when the pathology came back, it wasn't terrible, but it wasn't going to be great forever. No way I would have ever known about this until it was too late. So here's an interesting statistic. 1 out of every 500 virtual colonoscopy finds a colorectal cancer, but 1 out of 300, almost twice as many, find a non-colon cancer, renal cell cancers, lung cancers, lymphomas. I've seen everything. Pancreas. I've seen everything. Now, some of them, it doesn't make a difference. Either it's too late or there's nothing you can do, but a fair number of them do. So I'm on the page of, and I teach the radiologists, do not report silly things that require a big workup. Like if we see something in the liver, what we call a low density area in the liver, don't even report it, because then you're getting an ultrasound or a CT or an MRI and conscious, and most of them turn out to be nothing. So you have to be judicious, and we teach our radiologists to do that, but you're absolutely going to find significant things all the time. In terms of the other thing you mentioned about the one-stop shop for a colonoscopy, there's no argument about that. And I would be all for it if colonoscopies were completely safe and were the best test available. And with all due respect to my new best friend, Randy, I would say that if you look at the data, and I've probably done personally 8 to 10,000 of these things, that for finding, by the way, we're very good at finding flat lesions. The way to find, you just have to do the prep right and the insufflation right. And we do it, and I'm a stickler about this, but it's not, you can reproduce this easily around the country. So we're very good at finding those so-called flat lesions. As you said, who knows how important they are, but we can find them. Number 2 is that most patients don't have a polyp that needs to be removed. So 9 out of 10 people don't need it. So why would you put them through the risk and the sedation and losing a day of work? And although the risk is small, it is not zero. And from my point of view, a screening test should be no risk, because most people are normal. The vast majority of people who get screened for any test are normal. So there should be no risk. What I see in my best world is to do what I'm talking about: screen people with a risk-free test or near risk-free, and I think virtual colonoscopy meets that criteria, and then use the talents of a guy like Randy to treat the people who need to be treated. There's only so many of him, right? So when we want him to talk about, if we want him to treat people with inflammatory bowel disease, we want him to treat people with liver disease, we want him treating all these people. There's not enough of Randy Pellishes around the country right now to take care of all the people who have serious GI disease, peptic ulcer disease, H. pylori. I mean, there's a million things you guys do, right? Yeah. Don't paint these guys as just people who put a tube in somebody's rectum. These guys are smart, super educated, very knowledgeable, and treat a wide spectrum of diseases that many of us have or going to get. So I want these guys available to also to take care of patients. Let's do something. Let's put our brains together and our talents together and our techniques together to optimize this for patients. Give them a very safe test that's essentially risk-free, that's super duper accurate. It is at least as accurate as a colonoscopy, and then move them, those people to the Randy Pellishes of the world to treat. So we don't have to, not everybody has to have a colonoscopy, because only 1 in 10 of them or so is going to need Randy's skill to take out that polyp. So I understand Randy's point of view. Believe me, I have great respect for my colleagues in gastroenterology. My focus is, like yours, Randy, is let's put together a healthcare system that makes the most sense, it's the most cost effective, treats people in the safe manner as can, and gets the best possible outcome. So I'm sure we're on the same page in terms of our goals.
All right. Well, we could obviously, I love the fact that I can clearly see we're going to have offline conversations and you two follow up with or without me. It's totally okay.
You can come.
For purpose of just our time, we can wrap up and we can go through things there. I think you guys both just summarized really well, just that at the end of the day, it's all about getting people screened. We want more access to that so we can find things earlier, prevent things, or take care of things that we see as quickly as we can. And there's different options and there's different pros and cons of doing things, but I think you guys both did a good job of sort of, I think for me, bringing to light some of the reasons why you just want to have a conversation about these things. And right. And there's ways to get around the barriers of how hard it is to implement something new or to keep people in a room to have that done. So I really appreciate that. So if people are listening though, and say somebody wants to follow up with you guys directly, easiest way I'll put it into the summary at the end of, in our summary of the podcast, but do you want to just give an email, or do you want them to go to your LinkedIn? Either one of you, Mark, what's the best way to get a hold of you?
The best way to get hold of me is they can email me if they'd like. You can email me at mklein, MKLEIN, at colowatch, COLOWATCH.com.
And Randy, how about your side?
I'm at Randall, so RANDALL .Pellish, PELLISH at Leahy.org. That's my best way.
Okay, I like it.
Well, I'm just going to give Randy's personal cell phone numbers out there, and
my Union College email.
The running joke is we have special codes, so if we really need each other, there's a button you press, or you fake and decide it's either my mom calling in or his mom calling me, then we answer those phone calls, right?
That's fine.
Yeah, that's fine. What happens when you know somebody for going on 50 years? So
it's great, isn't it great? Yeah.
So anyway, I really appreciate you guys taking some time today, and we'll go from here.
Okay, thank you very much.
So much. That was a really fun 30 minutes. I enjoyed it.
I agree.
Yeah. Thanks for listening to Medical Imaging Matters, a podcast from AHRA, the Association for Medical Imaging Management. If you have enjoyed today's episode, please be sure to subscribe, rate, and review. AHRA is proud to be the trusted association for medical imaging management professionals, offering career development programs, a comprehensive selection of educational conferences and seminars, networking opportunities, award-winning publications, the certified radiology CRA credential, and so much more. To discover all AHRA has to offer, visit our website at ahra.org. Until next time.